Good evening, everyone. Welcome to my Avi Francis. Welcome to the European Fertility Society, and welcome, Dr. Elena Santiago. I'm glad that you are back with your topic tonight, and I'm glad that you are back because, of course, it's been a while since you've been here with us. So I'm glad you're back. How are you feeling? Hope everything is well, and you are ready to educate us a little bit as well.
Very good. Thank you so much, Caroline, as always. Glad to be here again with you all and hope that you enjoy the webinar today.
I'm sure it's going to be interesting. As always, remember, we have a topic on implantation window and how to improve it. And of course, Dr. Elena Santiago, gynecologist, fertility specialist at Clinica Tambre, located in Madrid, is here to help you. So first, she will start with her presentation on our topic, but afterwards, there will be time for your questions. I already see one of the questions ready. So thank you, Sarah, for your question. Remember, we will answer all the questions right after the presentation. So don't hesitate. You can type those questions even now, and Dr. Santiago will answer them for you after her presentation. And I'm glad that we are here. And as you know, we are gathered here almost every single week to support you. This is our second webinar this week. And I'm glad that we are able to do it and to help you out with any questions that you might have. And of course, if there's anyone who would like to help us out, a volunteer, we are still looking for some people that can help us with transcriptions. And if you would like to support us, you can also go to myevryfrancis.com website, and there is an option for you to help us out as well and support us. So I can only encourage you to do that. And I think that now it's time to start with our presentation. It's right here, of course. Dr. Santiago, are you ready to start?
Thank you so much.
Thank you indeed.
Okay. So let's talk today about the implantation window. Very important to understand how it works for fertility treatments, but as well for our general fertility lives, okay? So what are we going to cover today? First of all, we're going to talk a little bit about women's physiology and age, the menstrual cycle, the role of the endometrium, and afterwards we will be focusing in the window of implantation, checking the endometrial receptivity tests that we can do nowadays, seeing how we do an endometrial preparation for the embryo transfer, how the implantation process occurs, and at the end, we will be resuming the recommendations and ideas to take home. So, first of all, it's very important to understand how the women's physiology works, how is our ovarian cycle working, so that we can understand how we are calculating that window of implantation, or at least what we are talking about by the term window of implantation. So I believe you already know, but let me tell you that women are born with all their eggs in the ovaries. It's around 2 million eggs when we are born, and this can never be created new during our life. So it's very important, this understanding, because it's completely different to men, as they are going to create each 3 months new sperm. So it's completely different. Also, we always tend to think that we only lose 1 egg each month, but it's not like this. We are losing loads and loads of eggs each menstrual cycle. Around even 11,000 are going to die each month until we have our puberty. It means that even in when we are a child, we are going to lose loads of eggs, around 11,000 each year, even without having our menstrual cycle yet. So What happens with the puberty? Here, we around 10 to 16 years old. It depends a lot in each woman, but there are going to be significant changes in our life, in our fertile stage. What happens is that we are going to have a reactivation of the hormones. We say it's we call it the gonadotropin releasing system in our brain, and that activation is going to activate our ovaries, and therefore all this procedure is going to create our menstrual cycle. When this happens, our maturation of the reproductive system is going to take place. We are going to have also a very significant bone growth, and our sexual secondary characteristics will develop. And we call the menarche when our friend's menstruation is going to arrive. So, as I said, we are losing eggs from that quantity that we were born. We're going to lose until our adolescence, and we are going to have around 400,000 eggs left when we are in our puberty. And from there, we are going to lose even around 1,000 eggs in each cycle. And this is completely independent, even if we are under contraceptive pill, or we are pregnant, or we use nutritional supplements. At these stages also, we're going to lose eggs around 1,000 each month, even if we are not having cycles. Also, it's very important to take into account that our lifestyle could affect the quality and also our ovarian reserve. And also very important to take into account, because this, I believe, many women think that if we are doing a fertility treatment, an IVF treatment, or an ovarian stimulation, we're going to lose more eggs, or we're going to affect our ovarian reserve. No, it doesn't affect at all. When a woman runs out of ovarian reserve, that means that the ovaries are going to stop producing hormones. You will understand now. I'm going to explain how the cycle works, and therefore the menopause will begin. But the menopause is not established until there's 1 year, 1 whole year without any menstruation. So how the menstrual cycle works, as we said, is that gonadotropin liberation of hormones, the gonadotropin, are liberated in the brain, and these hormones basically are the FSH and LH, will be stimulating the ovaries. The ovaries, at the same time, because of the stimulation and because of the growth of the follicles, are going to produce estrogens, and after the ovulation are going to produce mainly progesterone, as well as estrogens, but mainly progesterone in the second phase of the cycle. We're going to understand all this right now in the following slides. So here we are. Here we're comparing the levels of LH and FSH during a cycle, starting with the period and ending with the next period around 28 days after. What's happening in the ovaries is that with the stimulation of the hormones that come from the brain, there's the follicles that we have inside our ovaries that month. One of those cycles is going to grow. Okay, we say that this is the dominant follicle, and normally this follicle will produce ovulation afterwards. That's when the levels of FSH and as well we call the increase of LH will produce that ovulation. After ovulation, there's still a structure inside our ovaries that is called corpus luteum, and this structure will be producing the progesterone. Here you can compare everything I explained with the hormones produced in the ovaries. At the first stage of the cycle, the ovary is producing loads of estrogens until ovulation occurs. And here you can see that, well, it decreases a little bit, but estrogens are kept or are being also produced in the second phase of the cycle. But it's very important, as you can see, also the difference of the progesterone levels. They are going to increase a lot more after ovulation, as we said. These estrogen and progesterone hormones are super important for the endometrium. The endometrium is the inner lining of the uterus, and it keeps on growing, and it will grow. And afterwards, if there's no pregnancy, this is the tissue that is going to produce the bleeding during menstruation. Okay, so at the start of the cycle, because of estrogen levels, this tissue is going to grow, and after ovulation, this tissue is going to be more receptive in the luteal phase, the secretory phase. Here it is, and the progesterone is going to help for that implantation to occur. As I said, if there's no implantation, then that's when the tissue is going to be renewed, causing the menstruation. So as you've seen, the role of the endometrium is super important for the implantation and development of the fetus. Due to the ovarian hormones, as we've said, the endometrium is going to change every month. Estrogens is the first part of the cycle, is to produce thickening of the lining, and the progesterone, as we said, is going to prepare the endometrium for the pregnancy. It's going to supply the lining and stimulating the glands to grow to nourish the early embryo. So what do we call, or what does it mean when we are talking about window of implantation? This term is super important because it means it's a window because there are only a few days where our endometrium is really receptive for an implantation to take place. Recent studies are showing that every woman has her personal window of implantation due to alterations in the receptivity of the uterus. So it's described in literature that around 10 to 30% of the patients, we are talking here about obviously infertility patients, could have a displaced window of implantation. And that's why we're going to talk about all these today, because it's very important to understand that when doing IVF treatments, we are always calculating the window of implantation of our uterus to be ready or receptive for when we are doing an embryo transfer. And in cases where we have implantation failure, maybe there's a problem there because the window is different to what we thought or calculating, no? But well, let's say that in the majority of women, that window of implantation should be taking place or should be receptive, the endometrium, after ovulation. So as we said, this should be the menstruation. This should be the phase of the estrogens before ovulation occurring. Afterwards, this is all the secretory or luteal phase where the progesterone is produced, but the endometrium is not receptive at every point in this stage. It's only receptive normally like in between 6 to 10 days after ovulation, even less than that. So that's what we call the fertility window. And in each woman, it depends on when the ovulation obviously is occurring. So this is not exactly the same for every woman. Some women can have cycles of around 25 days, counting from the first day of menstruation until the next menstruation. And some women are having cycles of 35 days. We say that those cycles in between 25 and 35 days normally, theoretically, are going to be always ovulation cycles, even if they are so different. But to calculate where the window of implantation is, we have to see when that woman is ovulating, because it could be different from one woman to another, right? So regarding the symptoms, how could we identify that window of implantation? Well, normally it's easier to identify when ovulation is occurring. The symptoms that some women can have, others have ovulations completely asymptomatic, but it's true that many women can have symptoms such as nausea, abdominal pain, some spotting or vaginal discharge, very transparent. There are changes in our smell, in our breasts, even they can be more sensitive, in our temperature. So, I mean, there are lots of symptoms that could be telling us when ovulation is occurring at each cycle. And obviously, window of implantation should be, as I said, some days after that. It's around 5, 6, 10 days maximum. After that is when our endometrium is going to be receptive. Another way of identifying when ovulation is going to occur is by doing the urine tests that we call ovulation tests. It is recommended to do those tests so that we can direct a little bit our sexual intercourse when the symptoms are unclear. If the symptoms are clear, I think it's not needed at all. But as I said, there are lots of women that are completely asymptomatic, and that helps us to know when we are ovulating, and therefore try to conceive more clearly at those days where the ovulation test is telling us that we are ovulating at that point, right? So now we're going to, regarding fertility treatments, we're going to talk a little bit more about this window of implantation, or what we call receptivity endometrial tests. Because as I said, in the literature, it's already described that there are women with different windows of implantation, let's say, of what we thought, because there's that window of implantation is displaced. How can we calculate this? So nowadays we have techniques. Normally we can do an endometrial biopsy. It's a very easy procedure that can be done at the consultation, and that biopsy is going to analyze around 300 genes, and it's going to tell us whether that woman is pre-receptive, receptive, it will be a normal implantation window, or post-receptive. And therefore, these biopsies can give us a personalized, let's say, embryo transfer, so that we can do embryo transfer for that woman at a particular point. Okay, so it's very important to understand that we can do this at the consultation and see where their window of implantation is taking place. So that afterwards, after doing the testing, obviously, we are going to use the protocol that this testing is going to tell us, so that our receptivity is much better, and it should be improving the pregnancy rates. So when would these tests be indicated? Normally we use them in patients when they had several unsuccessful good quality embryo transfers. It's true that we say, or we call implantation failure after 2 or 3 embryo transfers. Normally at Clinica Tambre, we are going to always transfer in a blastocyst stage and very good quality blastocyst. So after normally 2 embryo transfers, we do recommend to start doing these tests to see if there's anything there that could be avoiding the pregnancy. Also, super important to have into account patients with previous unsuccessful euploid embryo transfers. It means if you've done a PGS testing and you are already doing a transfer of a healthy chromosomic embryo or euploid embryo, and as the implantation rates are normally very high, around 70%, if this transfer has been unsuccessful, even only once, we do recommend to go ahead with these testings. Also, we could, in general, recommend to every patient that wants to have a better approach before doing an embryo transfer. So there are patients that even they've been through many treatments, for example, and it's the first time that they are going to do an embryo transfer of an egg donation treatments, and they want to go ahead with it. Or even if it's their first treatment, they would like to know if their window of implantation is normal or there's any difference. Also, in patients that maybe we only have one very good quality embryo to transfer, they would like to do those testings before risking, let's say, that only embryo that they have. I'm not going to explain absolutely all the endometrial preparations that exist, but it's true that it is important that when doing endometrial testing, we are going to use endometrial preparation such as the one that we're going to do when doing the proper embryo transfer. As you know, there are different ways of doing a transfer, and normally after endometrial testing, we're talking about frozen embryo transfers, and therefore the preparation is going to be with or substituted cycle with estrogen and progesterone, or it can also be in natural cycle normally. There are other ways of doing it, less common, but also we could use, for example, gonadotropins, such as when we are doing an ovarian stimulation. It's very important always that we monitor the preparation with ultrasounds, and also doing always a progesterone blood test to see that the levels of progesterone are low, normally lower than 1 nanogram per milliliter, before we do the embryo transfer, so that this window of implantation works. This is exactly the same for the endometrial testing. We have to monitor that growth of the endometrium, see that the thickness is correct, and do a progesterone blood test before scheduling the biopsy. As you can see, this is the implantation process that occurs between the embryo and the endometrium. There are many different stages. First of all, the hatching occurs. That's when the embryo goes out of the capsule, let's say, and adhesion molecules will be surrounding the embryos so that they will react with the endometrium, making a position, and afterwards adhesion. And the last stage will be the proper invasion of the embryo in the endometrium. So embryo implantation success depends in, as you can see, many factors, but normally the most important factor will be always the gamete quality. And this obviously depends on the quality of the egg and the sperm. Therefore, embryo quality and endometrium status, it means that we have a good measurement of that endometrium, a good aspect, meaning it's 3-laid, and the correct window of implantation calculated. Also, the technique done during embryo transfer is important. so there can be a proper dialogue between the embryo and the endometrium, no? But those are chemical reactions that are going to take place after the transfer is done. And obviously, it is super important as well to have a suitable luteal phase support. This means that the progesterone levels during that luteal phase are absolutely correct, so that there can an implantation can take place. So, recommendations and ideas to take home today. As we've said, a good endometrium is essential for a successful treatment. We can always, and we have to always, personalize each treatment for each patient, using the different tools that we can do nowadays. And I can tell you that the endometrial testing that we were talking about today is very, very used at Clinica Tambre, because we do believe that it helps lots of patients that we have with, for example, implantation failure. Studies do show that this receptivity test will improve the pregnancy rates after an embryo transfer, but it will improve statistically, or at least it is statistically proven in those patients that underwent previous embryo transfers without a success. Apart of the basic examination with a vaginal ultrasound, we can also have a better knowledge of the endometrium function and receptivity with these endometrial tests that nowadays can tell us the window of implantation, but even with the same biopsy, you can tell whether the endometrium is healthy regarding bacteria, that there's no infection, and that the microbiome is good, meaning normally a good population of lactobacillus, that it's so important also for implantation and developing pregnancy. So the main goal always is to improve the reproductive outcomes. So if we can use these tools, why not do so in those cases, as we said, personalized, where we believe it's going to improve our rates. So I hope you understood and enjoyed today's presentation. And obviously now I open to all the questions that you have. And thank you so much for your attention today. It's been wonderful to be back with you all.
It's great to have you back, Dr. Santiago, for sure. Thanks a lot for explaining how it all works. And well, now it's time for your questions. As we've mentioned already, there were some questions even before we begin the presentation. So let's get going to the questions. There are some of those ready. And I believe we can start with Sarah's question, the first one. I have done an ERA 1.5 years ago and it was found post-receptive by 12 hours. I have since then done 3 transfers with no success. 2 months ago, did a hysteroscopy with curettage, also found a septum which was excised. Do the ERA results still apply, or do I need to perform it again?
So normally they recommend for these endometrial tests to renew them every year, because they saw, or it is described in the literature as well, that that window of implantation could change. I don't think it's because of the curettage for sure, but more to do with the time. So 1.5 years, I do recommend to do it again, even to see, well, obviously to improve your reproductive outcomes.
All right. Thanks a lot, Sarah, for your first question. There is a follow-up. I will go straight to this one. What is the ideal progesterone level prior to transfer?
So when you are already taking the progesterone, we normally measure the levels 2 or 3 or even 1 day previous to the transfer. And there we recommend, at least in Clinica Tambre, our protocol is to have at least 10 nanogram per milliliters. if that if your progesterone in that case is not enough, then we should add up normally progesterone shots so that we can have those levels corrected before embryo transfer, and even obviously keep on with that treatment afterwards so that we are sure that your levels are going to be fine.
Thank you, Sarah, again for the questions. I believe that was helpful, and I believe so. There's a thank you as well coming up your way. Claire has another question. 42, I'll have a frozen embryo transfer my own eggs in a few months. What can I do to maximize the implantation window?
Sorry, I'm reading again the question because I got...
No worries.
So to maximize your window of implantation, as we've said, if you only have one embryo to do the transfer, then go ahead and obviously, as always, do endometrial preparation, having a good monitorization of the endometrium, meaning a good thickness, at least 7 millimeters, triple line, and before adding up progesterone, check that the progesterone levels are lower than 1.0 nanogram per milliliter. If you want to improve maybe a little bit more your success rate, it will be better if you could do that endometrial testing to see window of implantation. But I also recommend that you go ahead and check your microbiome at least and see if everything is correct over there.
Okay, brilliant. Thank you so much, Claire, for your question, and Santiago for your answer. What about a modified natural cycle? Anything you can add here?
Yeah, I believe a lot in natural cycle. I mean, it works in the same way. Pregnancy rates don't have any differences between substituted or natural modified cycle. The only thing to take into account is that for that case, we do need to have regular cycles. The woman has to have regular cycles, obviously, and our ovary has to work properly, meaning that we see that the follicle is growing, that at the same time the endometrium is preparing correctly, and it has a good lining, and that we provoke ovulation at the correct time, meaning that the progesterone levels are still low, so that we can calculate, normally it's a week after the trigger, for the embryo transfer. But I do believe in a natural cycle too, absolutely.
Okay, brilliant. Thank you so much. Claire has a follow-up. Let me go straight to this one, and we will go back to the previous ones. Thank you. When should the ERA test be done? What is the microbiome test name?
So the window of implantation test needs to be done at the same point as when we are doing an embryo transfer. So we calculate it exactly the same, but in that cycle, we do the same endometrial preparation as I said, but instead of doing embryo transfer at that point, we are taking the biopsy. It is super important to register the time of progesterone that we've been before doing the biopsy, and therefore they can calculate whether if our endometrium is receptive at that point, they can calculate the hours of progesterone that we will need for an embryo transfer. And what is the microbiome test name? Well, nowadays there are lots of commercial names for that, meaning that there are many enterprises that are already doing this. It depends on the laboratory, but for example, we in Tambre we do one that it's called Meta. Others are called Emma and Alice. Maybe that you've heard that before, but I mean, it doesn't matter the name. The important part here is to check the microbiome, and also, as I said, see if there are any infections regarding the endometrium.
Okay, brilliant. Thank you so much. In the meantime, we did receive a question on microbiome, so let me show you. So when the microbiome tests may be done, is it a complicated and painful procedure?
Always, an endometrial biopsy can be a little bit painful, but it's not so complicated. It shouldn't be so complicated. It's done normally at the consultation. It's a little bit painful, or at least you can feel it a little bit more than the embryo transfer itself, because the catheter is a little bit thicker and, sometimes a little bit difficult to get inside the uterus and aspirate the endometrium. Also, the cells for the biopsy to be taken could also be a little bit painful, but it's normally just a few minutes, and that's it. It's a quite quick procedure. The microbiome test itself can be done at any point of your cycle, except when you have your period. And to make the procedure less complicated, I always advise to come the day of the biopsy with a full bladder.
Okay, again, thanks a lot. Can you do an ERA test 5 days after egg retrieval?
Yes, you can, because there is when your window of implantation should be receptive, because it's when you're doing a fresh embryo transfer. But it's true that nowadays, at least at Clinica Tambre, we are doing so many frozen embryo transfers. And normally for ERA test or window of implantation testing, this will be done with substituted cycle or natural modified cycle, not after the ovarian stimulation. And why is this? Because we are doing the testing at that point. Afterwards, when you are really going to transfer the embryo is frozen and you have to prepare endometrium. So the only option you will have there is to do it exactly the same with the gonadotropins. And as I said, it's not the most common protocol. It works very good, but I think it's much cheaper and easier to go ahead with substituted cycle, meaning taking estrogens and vaginal progesterone or natural modified cycle.
Okay, thank you so much. In the meantime, we did receive one more, so I think we can go through this one. Is the ERA test also done through biopsy? Can this test be done together with the microbiome test?
Yeah, the ERA test is always done by a biopsy. And as I said, it could be done together with the same biopsy as the microbiome test. The thing is, when you're doing the biopsy, just let the lab know what kind of test you want. If you want only window of implantation, or you want to check also the microbiome, to also, as I said, see if there's any endometrial infection that we call endometritis.
Okay. One more, actually, regarding ERA test. So does it include CD138 test, which I believe tests for endometriosis?
So ERA test is window of implantation. CD138 is immunohistochemical test that is not the same as the ones that are normally done regarding the test that we were talking about. I mean, CD138 is only to see if these plasmatic cells are positive in endometrium. Normally, they are indicating that there could be an infection. But when doing the tests that we were talking about, normally as they are looking at genes and bacteria directly, they are more specific and more sensitive than CD138. But it's true that doing a biopsy for CD138 is cheaper than doing the other biopsies that we were talking about. So it's also used from time to time in at least at our clinic or in fertility clinics.
Okay, of course, thanks a lot. And let's have a look, okay? Let's have a look at the last one, sorry. How much time the treatment for the microbiome take place, if any, after the test?
So it depends on what they find out. If you have an endometritis or an infection, you need to go ahead with an antibiotic treatment that normally will take at least 7 to 10 days. And normally they will recommend you as well to go ahead with a probiotic treatment, even orally and vaginally at the same time. And this could take around 2 weeks' time. If you had an infection, they could be asking you to repeat the biopsy again to check that there's no more infection after the treatment. If the only treatment is regarding dysbiosis, this means that microbiome wasn't good, then normally they don't need to repeat the biopsy, and therefore you should only need a treatment of probiotics until you do the next embryo transfer, but it shouldn't be delayed because of this.
Mm-hmm. Okay, again, thanks a lot. And one more follow-up. So is endometritis, I think, painful, or it may be asymptomatic? Can it be seen by ultrasound?
That's the point, that endometritis normally is not painful. It is normally asymptomatic, chronic, and we can't see it in the ultrasound. Maybe you can suspect when there's a patient that is not preparing properly, meaning that the endometrium doesn't look good or doesn't look as it should, or the thickness is not growing, even if you are doing a treatment for that, then sometimes we do suspect that there could be some infection at that point, but it's not something that we can see visually with our eyes in an ultrasound.
That's the problem here, right? Thanks a lot, Marina, for your follow-ups here as well. And we will go to the previous question. So we had some most recent studies have confirmed that ERA receptivity don't increase chances of live birth. I personally had 2 ERAs within a month apart with different results. My transfers of PGT tested embryos were unsuccessful. Anything you can add here?
So it's true that there's a very questioned, or at least there's a lot of debate regarding this last study that went out with ERA receptivity tests. But we have to take into account that the only problem here is that they were testing every patient, not only the ones that I think need an implantation, window of implantation testing. I mean, if you do a study to every patient, it's different when including in the study patients with implantation failure. At that point, ERA does improve the results, but it doesn't improve the results when doing it to every patient. If you remember at the beginning of the presentation, we said that around 10 to 30% of patients could have a displaced window of implantation. So therefore, not every patient is going to need this type of testings. I don't know the reason why, with a month apart of 2 different ERA tests, you have different results. That shouldn't be like that. And I'm very sorry that your transfers obviously were unsuccessful, but here we will have to look at other factors that maybe could be also affecting implantation, not only the window.
Mm-hmm. Okay. Hope that helps. If you have anything else you would like to add, of course, you know what to do. Let's have a look at the next question. If you can clarify, menopause women can have embryo transfers? If, how can we find implantation window?
Very good question. I like it a lot. So it's true that we were all the time explaining our cycle when the window of implantation occurs. menopause women can have embryo transfers without any problem, because menopause means that our proper hormonal cycle is not working. But if you give that woman supplements with estrogens and progesterone, the uterus responds as if the ovary was still working. So here, there's no problem at all. The uterus will respond to the hormonal stimulation or preparation, and therefore we will find window of implantation, or we will calculate window of implantation depending on the days of progesterone that we are giving at that point. It means that first of all, we're going to prepare endometrium only with estrogen. Once we see that the thickness and the aspect of that endometrium is correct, we will be adding progesterone. Normally it's 5 days, during 5 days, completely before an embryo transfer. So that's how we are calculating window of implantation in menopause woman, or when doing substituted cycles during fertility treatments for embryo transfer.
Again, thank you so much indeed for the clarification. Marie, I believe that was again helpful. So is the window of implantation each time different? I mean, should the endometrial test be done during the preparation of endometrium for the implantation? What about the test for the bacteria? How is it called? We've mentioned this, but if you can clarify that.
Yeah. So the tests for the bacteria are called different names. Meta, the one that we are doing at Clinica Tambre. Sometimes also they are called Alice, Emma. Many other names, commercial names are around nowadays. And the window of implantation should be each time different. It shouldn't be more or less the same for every patient. It's true that within time this could change, and that's why we were saying that if you have an endometrial test for that, that's been done after more than 1 year, I do recommend to renew it. But it shouldn't be changing at every cycle or every point. It should be normally the same for every cycle.
Okay, again, thanks a lot. And let me see, there are more questions, a few questions left. If you have more, go ahead. There is still time to ask. So I have had 2 frozen embryo transfers with donor eggs. The first one was a chemical pregnancy. The second was a straight negative. Would I be a candidate for an ERA test?
Okay, yeah, 2 frozen embryo transfers, we were saying it's an implantation failure, but and obviously with donated eggs, it's even more recommended, because we are saying that the embryos were, I suppose, very good quality, because they come from donated eggs, which should be from very good quality too. So therefore, when we are having 2 negative embryo transfers of this type, I do recommend to check not only window of implantation, but other factors as well, such as see that, your uterus morphologically is correct, maybe do other immunological or blood testing to see if there are any other factors that are avoiding the implantation.
Okay, good. And which is best, regarding progesterone supplementation after embryo transfer, vaginally or injections?
So here we have to see with each patient what they prefer. I mean, best is injections, because we do know that the absorption of the product is complete, and we do know that the levels of progesterone are going to be absolutely correct. The thing is that injections normally are much more uncomfortable, obviously, and also much more expensive. So we normally tend to use, first of all, the vaginal pessaries and check the levels of progesterone of each patient, because it's true that not all patients are going to need the injections. But it also depends on the person. There are patients that prefer to go ahead with injections directly and not test the progesterone levels. It depends.
Okay, makes sense again. Thanks a lot. Thank you for your question indeed as well. Okay, let's see. The next question is, if you have a problem with the microbiome, the implantation will not happen, or it can happen, and you will have risk of having a miscarriage.
Correct. Microbiome, nowadays, they said, because of the literature or all the studies that are published, that can affect implantation rates and also a developing pregnancy. So it means that, for example, if you have a patient with recurrent miscarriages, meaning that obviously there's been implantation, you can also check microbiome, because sometimes this is the reason why those pregnancies are not developing.
Okay. Again, thank you for the clarification. It's important to remember. It's still, I think, a new kind of field, let's say, but it's important to remember about it as well. And if ERA is not done in the clinic where I have the last embryo frozen, what would you recommend? If I do ERA in another clinic, could it help for the next preparation of endometrium?
Well, it should help, absolutely. If for whatever reason they don't do it at your clinic, and you can find another place where to do the window of implantation testing, I do recommend to go ahead with it. And obviously, this could help for the next endometrial preparation, for sure.
Excellent. Thanks a lot. There are 3 questions left, so we will be slowly finishing. If there are some more questions you would like to ask, you know what to do. And the question is, so can you clarify what kind of supplements, what else will it be needed to get prepared, and how long will it take before being ready for embryo implantation?
Well, this is a very general question, very difficult to answer, meaning that, well, there could be lots of supplements to take, but as always, depending on the case. Let's say that mainly the supplements that will have to be taken will be folic acid to avoid neurological problems in the fetus, as well as vitamin D. Nowadays is very recommended as well. If, for example, levels of vitamin D are low, normally with 1 month of treatment should be enough for you to be prepared for an embryo transfer. So we shouldn't delay a lot the timing for that embryo transfers. Other supplements, I'm talking about probiotics. Normally, it depends on the person and what they see in the test of endometrium, but at least you have to have treatment with those probiotics during 1 month. Even if you try an embryo transfer and it's not successful, you should continue with those probiotics at least between 3 to 6 months. Other supplements, that depends on the person, but generally not recommended.
Okay, brilliant. Thanks a lot. So you mentioned checking the uterus morphology. How do you recommend this gets checked?
So I think that the less invasive technique nowadays, we have the 3-dimensional ultrasound. It's very good, very similar to IRM, and as I said, it's super useful, the 3D scan. If not, also with a hysteroscopy, that's when you introduce a camera vaginally inside the uterus and you can see directly the uterus cavity, is also very useful, but obviously more invasive.
Of course, but there are options for sure.
Yeah.
Sure. Thanks a lot indeed. And which route is best for probiotics, oral or vaginal?
So this depends also what they see in the microbiome testing.
Right.
It is described that vaginal probiotics are better because they do get more directly to the uterus, let's say, because of proximity. But sometimes also we do need those oral probiotics to have as well our flora from our bowel correct. So, I mean, sometimes even both of them are recommended. But if you have to choose with oral or vaginal, I will go for vaginal better.
Understood perfectly again. Thanks a lot.
Thank you.
Sure. Okay. Let's see. In my case, the thickness of endometrium was good. During the preparation of endometrium, I did ultrasound, progesterone tests several times. After the last one, I was prescribed the medication. The date for the transfer was set. Do you think the levels were satisfactory and they understood when the endometrium is ready? Do you think ERA had to be done?
So, I mean, here there are different aspects. You're saying that the thickness of endometrium was good, that I suppose that the progesterone levels were good. And obviously, when they set the transfer, they're calculating at that point the window of implantation. So here, your endometrium should be ready. An ERA doesn't have to be done, or a window of implantation test doesn't have to be done always. As we've said, normally it's in particular cases, depending on the fertility history, more recommended in implantation failure, meaning that you had several unsuccessful embryo transfers before. So it doesn't need to be done at the first endometrial preparation where you're suggesting that the thickness and the levels of progesterone were good, I suppose. I mean, it doesn't mean that if that's good, we need as well, yes or yes, a window of implantation testing. It depends on the case.
Okay. Again, thank you a lot. Let's have a look at this question. So, can you cover the last point of the slide about ovulation? It said something like it doesn't help implantation if didn't mention to read it properly. Could you go over this slide? And yes, we can. Let me just see which one was this? Ovulation. The last one.
There were several slides of ovulation, but
exactly.
Please, that I don't know what slide you're meaning.
Yeah, I'm just reading this. It said something about doesn't help implantation if not sure, but just I want to remind you in the meantime that this has been recorded. So remember, you will have a chance to rewatch this. Or if you can explain what you mean exactly, it will be easier for Dr. Santiago to answer properly. Okay, so please clarify what you mean, and be happy to go back. Okay, because at this point I'm not really sure.
Neither.
Honestly,
I'm so sorry.
Yes, but of course remember that if you wish, then you can still type some questions. And let's go to the question from Marie in the meantime. When you are in menopause and you are trying to become a candidate for embryo implantation, what treatments should we do prior implantation to prepare the area, etc.? Do we have an age limit for embryo transfer?
So that's the thing. Normally, you won't need any prior treatments for implantation rather than the proper endometrial preparation that we were saying. And there's no age limit for embryo transfers legally, normally. But obviously, ethically and medically as well, for sure, we do need to put a limit. So it depends on the clinic. For example, at Clinica Tambre, our limit is 50 years old, which is a very common limit in many clinics, let's say. But it is because due to age, there could be like more risks, for pregnancy for both the woman and the baby. So therefore, that's why we are putting that limit. But in reality, if you give as I said, hormones, even to patients that are older than that, the uterus is still going to normally respond to the treatment and could an implantation could take place. I mean, so we could do treatments at any age, really.
Yeah,
but
of course, that makes sense, and I hope that helped. Marie, thanks a lot for your question. Someone is typing, so I just want to make sure we'll be finishing, but someone is typing, so let's give it a second. Let's see if we have another question. If not, remember, if you have more questions, remember you can get in touch with Dr. Santiago, her team at Clinica Tambre directly. I'm sure they will be happy to help you out with any questions that you might have. And I know that you always need some more details to give a proper answer, some medical results, some history to give a proper result and proper answer. So yeah, that's about it. And in the meantime, we did receive two more questions. Do we have an age limit regarding receiving eggs having already the sperm donor?
So the answer to this is the same as I answered before.
Yeah.
In biologically, there's no limit in receiving eggs because the uterus still is capable normally of holding a pregnancy, but obviously it depends on the health. So that's why normally we put limits in age.
Okay, thank you for the clarification. And possibly our final question from Arena. I had 3 unsuccessful transfers, but the doctors tend to blame the embryo quality. Maybe that's why ERA was not done, but if only one frozen embryo was left, would you recommend to do ERA and other tests once the chemical pregnancy took place?
Yeah, even with chemical pregnancies, they do recommend to do window of implantation testings because they say that this could be one of the causes of a biochemical pregnancy. Even if embryo quality is not very good, but still you have one embryo left, it is good to go ahead and do more testings, see what your window of implantation is. And obviously, I hope it does work. But if it doesn't, then you already have more evidence for future treatments, and therefore you can know where your activity is normally taking place.
Brilliant. Thank you so much, Marina. Best of luck, as always, to everyone. One more last question for tonight. Can we arrange a one-to-one follow-up after this webinar to understand the options available? And I'm sure it's possible. I can only encourage you to get in touch with Clinica Tambre's team, right, to arrange a consultation. I think it's possible, Dr. Santiago, right?
Absolutely.
Brilliant. I think that there is an email address right here, right? So if you wish to get in touch directly with Clinica Tambre and arrange a consultation to get some more details, you can get in touch with them. As you can see, information at clinicatambre.com. This is the email address you can use. But of course, you can also get in touch with me. I'll be happy to forward this if you prefer. Dr. Santiago, brilliant questions, brilliant answers for sure. Thank you so much for joining us tonight. Anything else you wish to add before we end for today?
Thank you so much, Caroline, as always. What I do add is always personalize every treatment. Each patient is different, and it's very important that we focus in each patient differently.
Definitely. And thank you so much indeed, everyone, for your time, for your questions. I believe it was really helpful for you. Remember, we will be back. And of course, there are more events coming up. Actually, next week on Tuesday, we will be back and we will discuss microbiome with Maria Navas. So if you wish to get some more details, you can join us and find out a bit more on this aspect as well. And of course, thanks everyone. It has been recorded. So if you missed any parts, you will have a chance to watch this. It will be available on our website tomorrow and on our YouTube channel as well. Dr. Santiago, looking forward to some more events. I know that we will have another chance to meet very soon as well. So thanks a lot for tonight. Enjoy your evening, everyone. And looking forward to the next one, okay?
Thank you so much to everyone.
Thank you.
See you soon.
Good night. Bye.
Good night. Bye-bye.